All right. Which one? Say it louder. Yeah. All right, good. Why? Yes, because that one should not have any impediment to return circulation. So if there is, especially an isolated right-sided, they need to see if there's any retroperitoneal pathology and see if there's anything impeding that circulation that shouldn't be there. Which one? B. As in bed care. Yes. Bed care. I would try. Right? You can argue about that all you want, but that's the answer. Okay? I know you're an EMED brain, and ultrasound is the answer to everything.
Yes.
All right. Find the hidden word. Yes, I hate these questions too, but every once in a while it's fun.
Isolated left side.
Isolated left side, right? Okay, everything else is sort of a warning. Bilateral, okay, E, I would still get it, and I would lean it into the side of caution. So if there's a right-sided present, I would just get it just to be 100% sure. Okay, rapid enlargement does not regress with supine, and isolated right side are all sort of those warning signs that there may be some sort of mass impinging on the venous return. So we need to see if it is there and what exactly it is. All right. Any questions? Let's go talk about prostate today. All about the prostate, everything you ever wanted to know. And again, this lecture seems bulky in slide number, but there are a lot of slides in here that are background information for you only. Remember, I don't know if you remember, but I don't ask any treatments about cancer or surgical approaches because those are decisions that you will make. So the level that I need in here is familiarity. So when we get to prostate surgery for BPH, when we get to prostate cancer treatments and staging and scoring, I just want you to be familiar with that. That's not going to be specifically on the exam again, because that's not decisions that we'll make. So if you look at the slide number, like 94 slides, it's not as bad as it seems, okay? I guess I'll start how I always start. Is there any questions up till now? All right, fantastic. So the prostate is a problem just based on its anatomical location, all right? And specifically the part where the urethra passes through it. That has the majority of the presenting symptoms that you will see with prostate tissue, all right? And the real problem is with prostate cancer that when you do a digital rectal exam, just based on its location, you can only appreciate a certain part of the gland, right? So a negative DRE doesn't reassure you 100% that this patient doesn't have a lesion that you can't feel somewhere in the interior of the organ that you are not able to appreciate with the DRE, right? So looking at that, the real problem areas for us, I should say, for the patients who have BPH, would be the transition zone, which is the area that's right immediately around the urethra. That's where we have a lot of the ingress of the urethral diameter from benign prostatic hyperplasia. So that's where the patient starts to elicit those symptoms of obstructive urinary problems, right? Difficulty with voiding, getting up all the time, nocturia, so on and so forth. One thing that is slightly reassuring is if you're looking at this, okay, so as it says here, location of the rectum. So this green portion right here, which is the peripheral zone, that's the part that is palpable. And if you look here, it's also the site where most cancers grow. But again, most, not all. So what does that mean? It means many prostate cancer lesions will be palpable on DRE. Many, but not all. Think about that. That's about, let's say, a little bit less than half, maybe 40% of the gland. So the remaining 60% you can't really appreciate. So that means that you can't definitively rule out prostate cancer without a lesion on DRE. Does that make sense? It seems like an obvious point, but it needs to be one that's very, very clear. Okay? I'm going to tell you two things when we talk about DRE. The things that are suspicious, the most suspicious for prostate cancer, and remember them now and all the way for the rest of your career. Any kind of areas of induration. What is induration? Hardness on physical exam. Any areas of induration or any asymmetry. All right? Asymmetry on a DRE. And why? I know we haven't talked about, but what is the nature of benign prostatic hyperplasia? What's the nature of a hyperplastic process? Growth of the entire organ, right? Not growth of one side or the other, right? So if you have simple BPH, benign prostatic hyperplasia, the exam should be equal on both sides. When you appreciate the gland, it should feel the same on both sides. If you have something that's growing on one side but not the other, aka prostate cancer or malignancy, then you're going to have an asymmetry. Does that make sense to everybody? Okay, and the same thing with the induration. That's what you're really feeling. Benign prostatic hyperplasia should feel essentially normal, maybe a little spongy, but essentially normal. It should not feel hard, and there should definitely not be a fixed area of induration. So just put that in your brain as we're moving forward, okay? And I want to use this slide as a jumping off point because we're going to start with infections or inflammatory processes, I should say. Then we're going to go to BPH, and then we're going to finish with prostate cancer. So if you look at this slide, these are the classification for all of these pseudo-infectious / inflammatory processes. And it looks like they all sound relatively the same. There's a ton of them. How do I keep them separate? But let's do this as a thought problem, okay? The way I tell students is as you go from, and forget about 4 for a second, all right? Just go 1 to 3B, all right? As you go down, essentially what you do is you take away something, right? So you take away a symptom or a sign or a finding, all right? So with acute bacterial prostatitis, what do you think the presenting sign symptom is going to be for that patient? Pain and fever. I heard them both, okay? You're both exactly right. A lot of pain and fever. Exquisite tenderness. We'll get to all that. But why acute? Let's just put it that way. Acute. It doesn't mean anything, but acute means it's going to be generally worse, right? Bacterial, so what does that mean? Literally it means the presence of bacteria, which would then give you the fever, okay? And then prostatitis, and the itis is what? Inflammation, swelling, pain, okay? Now, go down. Chronic bacterial prostatitis. Here, the title doesn't necessarily give it away, but what you take away is the acuteness of the pain. Exactly. The pain is significantly less, all right? So the patient usually won't have a fever either. Okay, so you go from an acute presentation to a more low-lying, insidious, chronic presentation. And why am I doing this thought problem? Because 1, it'll help you with patient care if you put together all the symptoms in your head. 2, on the exam, as you're reading them, you're checking off either this is present or this is absent and helping you get to the immediate diagnosis. All right? So, acute bacterial prostatitis, a lot of pain, fever. Chronic bacterial prostatitis, less pain, no fever, okay, generally. Chronic prostatitis, pelvic pain syndrome, inflammatory. Well, just what word is missing from that one that was on the previous 2? Bacterial, right? So what does that mean? It means you don't have any cultures that are positive. You have white cells, you might have some leukocytosis, you might have white cells in prostatic secretions, but you don't have a true infection, right? Pain, pain, pain. Pain is still there, okay? And you have the inflammatory. And the inflammatory means inflammatory markers, and what does that usually mean for us? ESR, CRP, white cells, right? Make sense? Okay. Now we go down chronic prostatitis, pelvic pain syndrome, non-inflammatory. What do you think the only sign or symptom we have left for this patient is? Pain. And itis, what else? Inflammation. So pain and inflammation. You see what I mean? You see how that works? So you go acute pain, a lot of pain, fever, less pain, no fever, no bacteria, but inflammatory still. and pain, and that's it. Non-inflammatory, meaning everything is normal-ish as far as our labs are concerned. And then we'll talk about that little zebra on the end. Does that make sense to everybody? How you're reading a question, whether something is, while you're reading a clinical vignette, what's present or what's absent is going to help you determine this is the, okay, well, fever, so it's got to be this one. Exquisite pain, it's got to be this one. Mild pain, no leukocytes. Or, you see what I mean? It's just a matter of putting that all together. And we're going to obviously do that now, but I just wanted to do that as a jumping off point. Hopefully that helps. We'll see. So acute bacterial prostatitis, mostly it's going to be E. coli. Mostly. Okay? The patient may or may not have a history of a recent UTI or an STI. Right. And essentially this is a similar physiology to, or pathophysiology to our UTIs, right? Our UTIs, the bugs crawl up the urethra, make their way into the bladder or into the kidneys if we're talking pyelo. In this case, rather than going into the bladder, they go into the prostatic ducts and they make their way into that prostatic tissue, okay? But just exactly what we just said. Fever, chills, malaise. All of our pain in general with prostate is going to be in the perennial pain, right? They're going to have the pain between their legs, going to generally radiate to their low back. The patients with acute bacterial prostatitis may actually do that saddle walk, sort of an antalgic gait because it hurts when they walk, so they might actually have a bit of an open stance gait, like a cowboy walk, you know what I mean? Because it actually feels better to them to not irritate so much, and they're not going to be walking generally upright. This one really does hurt the patient. Okay, it's exquisite tenderness is what you'll find when you do a TRE with this one. Okay. Irritative voiding symptoms are usually more predominant, and the irritating ones are the irritating things like urgency, some pyuria, dysuria. Okay. So it hurts when they go to the bathrooms in many cases. And depending on the degree of the itis, right, bacterial prostatitis, swelling, they may actually present with some obstructive urinary symptoms too, difficulty with voiding, difficulty with initiating their void, difficulty with maintaining a stream of urine. For physical examination, again, fever, and then the exquisite tenderness on DRE. Typically the DRE, you will be able to appreciate excess warmth, hyperemia of the prostate, and the guidance is to do a relatively gentle DRE, don't push down hard to try to really appreciate, if you're doing it for, BPH and not in this setting, if you're really trying to appreciate a patient that may, let's say, have a family history of prostate cancer, you may want to do a bit of a firmer palpation to see if you can appreciate any kind of lesions. In this case, you just really want to get a feel for it. Honestly, if you even do it at all, just to confirm, because you can actually seed the blood system, okay? So you want to do that. No, don't want to, excuse me. Again, leukocytosis, maybe blood cultures, but CBC is going to show this, again, inflammatory and infectious process, right? And you definitely want to get a urinalysis. You don't need these yet. Do you remember in pyelo, we talked about pyelo, if the patient doesn't respond to antibiotics, we may start to get concerned about renal abscess, right? Well, prostatic abscesses can form as well. So if you have a patient who is not responding to appropriate antibiotic care, then it may be indicated to get a CT scan or an ultrasound of the prostate. But in the initial acute period, you don't need any radiographs, okay? Is that clear enough? So basically just if the patient's not getting better, then we need to investigate further, similar to pyelo. Our differential diagnosis, it's pretty straightforward. Let's just be honest. This is another diagnosis that kind of presents itself pretty obviously. And our quinolones, as I have alluded to, are going to be generally our friends here in the prostate section, especially the prostate infections. Don't forget the reason why the patient came to us because of pain. So pain control is going to be very critical here. Antibiotics, unless this patient is significantly comorbid, they can generally be treated as an outpatient. All right. So these patients don't typically have to stay with us. The things that would necessitate the patient to become inpatient would be something like if they do have an acute urinary obstruction because of a severe inflammatory response. If they are showing signs of sepsis, things that are obvious, like clinically obvious things that, okay, this patient can't go home. But in general, most of the time this patient can, and then just needs a follow-up, okay? And let me go back just the same thing. You guys, same thing with all the other meds. You don't need to know strengths or durations, you just need to know meds, all right? So as you're studying, just remember that. So again, should be a fairly obvious list, and you don't need to know this one other than the fact that we're just going to go to IV, all right? So I'm not going to add, similar meds, add a little bit of gram-negative coverage, but we generally, this patient's going to be outpatient, right? If this patient comes to you and they are anuric and they can't go to the bathroom, or if they're inpatient and they develop anuria during their inpatient stay, we really want to try to avoid going through that prostatic urethra. So at that point, definitely urology needs to be on board if they haven't been already. Okay. And the prostate, the problem with it really, and if you go, I'll go back for just a second, not to flip back and forth, but we have a pretty long period of treatment, and the reason for that is because it takes a while for these antibiotics to become therapeutic in the prostatic tissue. All right. So because of that, it can be easy to undertreat an infection if we don't treat it for long enough. So we want to make sure that we get repeat urine cultures and make sure that the bug is completely gone. All right. Because one of the things that acute bacterial prostatitis can turn into, if it's undertreated, is then chronic bacterial prostatitis, and that thing becomes a harder thing to get rid of. Okay. Any questions? Pretty straightforward, right? So chronic, again, E. coli, but we're going to highlight what the differences are here. Okay, so there's the one we talked about. No fever and sort of more of a low-lying, insidious, like achy, dull pain, not an exquisite tenderness, all right? So this patient will be in pain. They will have an inflamed and enlarged prostate, but it will not be the presentation that is similar to acute bacterial prostatitis, okay? Now, express prostatic secretions, this is a real thing. Don't do it, all right? It will be done potentially in the urologist's office as a last resort to figure out exactly what's going on if this patient has chronic bacterial prostatitis. But let me just tell you, primary care, if you do suspect or diagnose chronic bacterial prostatitis, just send them to the urologist's office. All right, this patient should 100% be seen by them because it's notoriously difficult to treat. Okay, and so that is a real thing, to milk their prostate and culture secretions. Most urologists don't even do it, but it can be done if necessary. I just leave this picture in here because when I was first putting this lecture together, I found it and I just can't bring myself to take it out. But don't do that, all right? Don't do that. Because you're gonna screw it up and it's not gonna be useful, and then your patient will just have to undergo this really uncomfortable test for nothing. If they need it, the urologist will do it, all right? Same thing with this, you're not gonna order these tests, these are all gonna be post-referral, but in order to sort of identify the degree of obstruction, really is what these are for. Post-void residual is exactly what it sounds like, the amount of urine that remains in the bladder after voiding, after the patient feels like they're done voiding. So with an obstructive process that may increase, and what's the problem with an increased residual amount of urine sitting in the bladder? Infections, potential for infections, exactly, okay? And then the pressure flow, or the flow, the force of strain measurements, all that kind of things. Those are going to be done in the urologist's office if necessary. Okay. This one, the big differential diagnosis are going to be these guys. The two that we're going to speak about in the next, the chronic inflammatory and the chronic non-inflammatory, is really the differentiation between chronic and acute is very clinically obvious. With nothing else besides the fever. Okay. Outpatient treatment, fluoroquinolones again are our friend, and it's probably going to be an even longer course of treatment, and it's probably going to not always be successful. This patient can probably expect waxing and waning type symptoms as they're coming up more of a chronic problem, as the title implies, right? And why would we give alpha blockers? Yeah, open the prostatic urethra as much as we can, right? If they're experiencing, like if the obstructive voiding symptoms are high up on the list of things that are giving them problems, then if we can open that prostatic urethra through the smooth muscle relaxation, then we can help with relieving some of those voiding symptoms. And sitz baths, I'm sure you guys have talked about sitz baths before. Honestly, literally just sitting in warm water, it actually is a tremendous pain relief for patients who have all kinds of things in that area, anal disease, perianal disease, perennial disease, so on and so forth. There actually is something that patients find a lot of relief with. Okay. And again, takeaway for primary care is that this is a difficult problem to eradicate. A treatment is not that big a deal, but dialing in the correct treatment is the problem, and often it becomes a waxing and waning sort of, finding the right treatment that's going to relieve this patient's symptoms fully. Any questions? All right. Chronic pelvic pain syndromes. Now these are the other ones that we talked about in the first slide. What degree of inflammation is there really? It depends, So these become even more difficult sort of to diagnose. Again, diagnosis of exclusion. So what are we really excluding? We're excluding any infectious processes. And then the leftover with just an inflamed prostate for no specific infectious reason. Okay. These patients may complain of chronic ejaculatory pain just based on the squeeze of the prostate when that occurs. Right? So they may complain of pain with sex or with ejaculation during masturbation or whatever. They may complain of radiating pain into the testes or groin in addition to that perennial and low back pain. Okay? And again, with anything that is labeled or diagnosed as chronic pain syndrome, this one is difficult to treat and it's difficult to alleviate all the symptoms. Most of the treatment here is aimed at symptomatic relief, not necessarily relief of the inflammation, if that makes sense. Okay? So, again, this was from that first slide, this little thought problem we did. Leukocytes here because, again, it's an inflammatory process, so there's markers of inflammation. Right? The inflammation is sort of idiopathic, but we still expect to see that, and that's what helps differentiate it from the other one. Okay? And what helps us differentiate it from chronic bacterial prostatitis? Bacterial cultures, presence of bacteria, right? And multimodal treatment, right? So we're going to talk about pelvic floor physical therapy. We're talking about alpha blockade to help relieve some of the obstructive symptoms. Talking about anti-inflammatory medicines, NSAIDs, or stronger, depending on what this patient needs to get symptomatic pain relief, all right? And then non-inflammatory, we have essentially normal physical exam, normal labs, patient just has pain. Okay, so a true diagnosis of exclusion here because we really have nothing. Patient just has chronic pain in between their legs, but their exam is normal and all their labs are normal, right? And again, treatment is not that all dissimilar to what I just talked about. Sitz baths, symptomatic care. There's really nothing to aim at here. Although I will say in many cases, not anti-inflammatories or something as simple as Tylenol does help these patients a little bit, try to avoid them on a long-term pain medicine. Symptomatic care, if they need, did you guys talk about the WHO analgesic ladder? Like, kind of keep stepping, the whole holistic care goes all the way through, so we're gonna try to give them NSAID, acetaminophen, PRN. If they need something like amitriptyline or a TCA or gabapentin, whatever, then, and then if we have to escalate to narcotics, we will. But again, that's mostly what this is, just a chronic pain disorder. We have to take the pain away for the patient as much as we can. Quality of life issue more than anything. Any questions? I feel like I'm going fast. Am I going too fast? And then this one, don't worry about it. Asymptomatic inflammatory prostatitis. How do you think you find this one? On accident, right? Basically. You maybe do it at DRE, the patient has no symptoms, it feels inflamed or enlarged, it doesn't give them any pain, it doesn't cause them any urinary symptoms. Great, what do you do about it? Nothing. Okay? And then, this is what I was saying. If you go from acute all the way to non-inflammatory, essentially you're taking things away until you get mostly pus indicated things to everything absent or not there. Okay? That's the easiest way. If you're reading a question, you're examining a patient, looking for putting the story together until you get to the end, right? Pain, degree of pain, presence, absence of fever, presence or absence of inflammatory markers, presence or absence of bacterial cultures, right? So then, depending on how many you have, you move farther to your left. How many are absent, you move farther to the right. Clear enough? Ish? Yeah? For now? Huh? Clear as mud? Mud is way more obscure than that. That's not mud at all. What are your questions? Okay. All right. So seriously, anybody have any questions about that? Anything I can clear up for that? Because I want to. I mean, we have plenty of time remaining in the class. So if you need me to go back over something, I will. Anybody? Yeah.
I guess I'm a little confused about the chronic bacterial. All like anybody with filtering antibiotics.
Well, then you're going to find prostatic secretions are going to be positive. So the UA might not be positive because it might not be enough to really express it onto a UA, but a prostatic secretion, well, the other thing that you can do, which is why you don't usually do prostatic secretions, is culture the ejaculate, right? Have somebody do a post-ejaculation culture of that, because all the bacteria is going to be in the prostate. It's going to be in the seminal fluid as well, right? So you can have the patient do it themselves. So you can culture something. Something is going to be positive with chronic bacterial prostatitis, right? It may not be a UA. Does that make sense? Okay. And truthfully, the reason I don't go into that is because, I leave the sort of tongue-in-cheek, like prostatic massage thing. You guys really shouldn't be ordering, semen analysis culture, if that makes sense. Semen analysis for another reason, but if you're that degree, honestly, all of these chronic bacterial prostatitis patients, if you just can't, let's say you give it a round of antibiotics, it doesn't get any better, the patient needs to go to urology. Okay, it really is not in the primary care sort of realm. Now, you might manage them in their pain control and so on and so forth, but in order to getting to that granularity of like getting rid of the patient's symptoms altogether, it's really going to be more in the urologist. Does that make sense? Okay. Anybody else? Yeah.
For the chronic bacterial prostatitis, so the only study that we would be potentially ordering is the CMP, post-void residual, and all the others just like.
No, you wouldn't even really go order the post-void residual. The post-void residual would come after a consult to urology. Really, for us, we'd order basic lab, CBC, CMP, UA, right? UA might be negative, but again, something will be positive. The bacteria, ultimately, bacteria is the problem, whether they get it on the culture of semen, whether they get it on the culture of post-prostatic massage secretions, something is going to be positive. So that's the takeaway, right? Are we going to find the bacteria? Not necessarily, but does that make sense? And again, that distinction for what we can find between chronic bacterial and chronic inflammatory, which is its little brother, might be clinically silent, not obvious, right? So again, that's why we punt all these things over and let them do what they do, okay? Anybody else? All right, BPH. All right, bad news, fellas. It's coming for everybody, all right? The longer you live, the closer you get to 100% presence. Now, does that mean everybody's gonna have symptoms? No, honestly, it doesn't, which seems confounding, but your prostate just continues to grow, right? So the longer you live, the more likely you are to experience obstructive voiding symptoms, okay? So you see this, starting at age 40 to 45, 60 at 60, 80 at 80. You don't have to know those numbers, that just re-illustrates the point that the longer you are alive, the more likely that it's gonna happen, okay? And what do you need? You need testosterone, dihydrotestosterone. You need to get, people say, well, as you get older, your testosterone production declines, so why does BPH become more incidental as you get older? Because you continue to make testosterone, the prostate continues to be a very testosterone sensitive organ, so just the presence of testosterone that you do make can still continue prostatic hyperplasia. The prostate never goes to puberty and stops growing, it just keeps going. And our friend here, you might have talked about 5-alpha reductase inhibitors in pharm, and we will talk about them in here today. Okay? But essentially, 5-alpha reductase converts the testosterone into DHT, and the DHT is what turns then the on switch for prostatic cells to grow. Okay? And the real problem is that part of the most sensitive area, or one of the most sensitive areas to testosterone, is the transition zone, which is the zone that surrounds the urethra, which then, as it becomes hyperplastic, it makes the urethral diameter smaller and smaller and smaller and smaller, meaning that obstructive urinary symptoms continue to go up. Okay? And this is just, again, precision in diagnosis. Honestly, when I learned this back in the day, it was benign prostatic hypertrophy. All right? And the truth about it is there are hypertrophic and hyperplastic processes happening, but the difference is what? What's hypertrophy? Individual cell growth, and hyperplasia is cell increase, cell number increase. But the truth about it is both of those processes are happening, okay? And symptoms, collectively, is where we talk about LUTs. And I know you've heard me refer to LUTs as lower urinary tract symptoms, but that's what this patient is experiencing. So there's two different sides. We've talked about the irritated and the obstructive, but this patient will typically have a combination of both. One, the obstructive portion is just literally the obstruction of urinary outflow because of the reduction in diameter of the urethra. But then also there's a secondary response where the bladder gets angry and spastic and responsive, and so then you have a lot of the irritative signs and symptoms that go along with it. So this patient will have a combination of both. All right? And why does prostate size on DURE correlate poorly with symptoms? Anybody? Because you're not feeling the transition zone exactly. You're not able to feel that zone that goes around the urethra. So we're talking about outward growth that we can appreciate on DRE, but inward growth is what really is causing this patient's problems, okay? So you might have a patient with enormous prostate that has no problems whatsoever, just a lucky soul, I suppose. IPSS score. So I will tell you that urologists, this section of class, a lot of self-directed scores. And what this does is you have the patient fill it out. So if you have somebody that you know has a prostate or a obstructive or any kind of, you suspect a BPH, let's just say, excuse me, based on their chief complaint. If you can get your nurse, your tech, your medic to have the patient fill this out before they get to you, it's really helpful. And what it does is it takes subjective data and makes it objective. All right? So if I communicate to a peer that this patient has an IPSS score of 8, it means the same thing to everybody, right? But if I say this patient has mild symptoms, that means a lot of different things to a lot of different people. Does that make sense? So again, you put the score for this in your objective findings, like in the objective section of your note. And the score helps direct treatment, okay? One, it helps direct treatment at patient presentation because we know how severe their problems are. Two, it helps us understand if our treatments are making the patient better or not having any effect or even making them worse. Because when the patient comes back on their 6 whatever week follow-up, you have them fill it out again and we're looking for the score to have gone down, right? And if it doesn't, that means our treatments aren't working. We need to up our meds, add another med, change meds, or make a referral, right? Make sense? So it's very, very useful, very, very useful, all right? And not only communicate peer-to-peer, it also communicates to your consultants. So when it's time to send the patient, well, I'm sending this patient, they have a IPSS score of, 30. I'm gonna put them on meds, but they need to see you based on the degree of symptomology. And it tells the urologist, or maybe I need to, take this person, right? You don't have to obviously memorize it, but you need to know that it exists and you need to have your patients fill it out. And it's just a simple scoring system and you just add up the total, okay? You will also see this called the AUA score, but now it's the international. And I know it sounds like IPIS, I didn't make it up. IPSS score, it's a real thing, okay? So, and you really do want to have your patient, and all you do is you Google AUA score, Google IPSS score, have your patients, have a few of them in the front desk, so that if your patient has a achieved point consistent with this, they can fill it out, and you have it all ready before you get into the room. Okay. Other possible problem. What's the problem with prostate cancer causing symptoms of your obstructive or irritative symptoms? Exactly. It's got to be growing in the right place at the right time, right? If it's not growing, it doesn't happen to be growing in that transition zone. If it doesn't happen to be growing anywhere that obstructs your urethra, or irritates the bladder, you're not going to find it until it's really, really big. Okay. To go back, what did I tell you? I told you there's going to be an overlap of urethral stricture. What is the story meant for the urethral stricture patient typically? Surgery, trauma, maybe, yes, that's true. But what else? What were we talking about? Frequent STIs in a younger patient. So you have a younger patient who doesn't fit the BPH demographic, but is having similar obstructive type symptoms, okay? And a lot of times the cause is frequent urethritis, which leads to fibrosis, scarring of the urethra, and also decreases diameter. So the symptoms are going to be similar, but the patient doesn't really seem like he's old enough to have BPH, okay? Now, obstructive, let me tell you, on this side, you've heard all of these related to BPH before, I'm sure. Hesitancy, meaning the patient, typically urination is a low pressure thing. You go, you stand in front of the toilet, you sit down on the toilet, you pee, right? This patient doesn't start right away. They have to press down, bear down, engage their core muscles literally to push urine out, which then leads to a decreased force and caliber of stream, right? Urine literally is not coming out as strong as it used to because they have to engage their muscles because it has to overcome this obstruction. Patient typically feels like they haven't gotten everything out which then leads to double voiding. And what double voiding is I go to the bathroom, I get as much out as I can, go back within a short period of time, like 10, 15 minutes, maybe even half an hour, before your bladder should be full again, the patient feels like they have to go to the bathroom again. That's double voiding. I feel like I'm going to the bathroom, then I'm going right again. That's what your patient will say. Does that make sense? Okay. Straining to urinate, obviously, that should be obvious. And then post-void dribbling, just a thought question. What do you think your patient might think that is, post-void dribbling? Huh? You said something. Don't say something and try to look at somebody else. I heard you. What'd you say? Okay, discharge, close enough. I'll give it to you. No, but incontinence. So they may be hesitant to tell you about that one because they may feel like they're actually leaking urine because of an incontinent bladder. Now what that is not an incontinent bladder. This patient just had to strain so much, the literal remainder of the urine that's left in the urethra sort of dribbles out after they go to the bathroom. They leak urine into their shorts and they will remark on that, but you have to ask them that question. You have to sort of delineate that between true incontinence, all right? The patients are often kind of embarrassed about that. So if it's present, it's a pretty obvious sign of obstruction. Now irritative, like I said, these are the things that are irritating. And I'll tell you what brings this patient in most commonly. It's this. It's having to it's when they're asleep starts to become hampered. When they have to get up 3 or 4 times at night and they're not getting any sleep, and then they're irritated and they're angry and they're cranky all the time. More so even than the obstructive voiding symptoms, it's the nocturia that's going to bring the patients in and saying, I don't know what the hell's going on, but I'm getting up 3 or 4 times the fist every night. And I'm tired constantly, all right? But everything else, pretty obvious. Frequency versus urgency, dysuria, not super common, honestly. So if we have dysuria and associated with this, we might start thinking that this patient might actually have an infection in addition to, okay? That's why I have the stars and the other ones. They're pretty common with everything else. Does that make sense? But again, what's the potential dysuria problem? This patient has had BPH going on for a long time. Their PVR, post-void residual, has been increased. They have the urine sitting in the bladder. Now it's got an infection. DRE, this is what I have already told you. If this patient has either an area of induration or an asymmetry on exam, they need to go get an ultrasound right away. Okay, that's what TRUS, transrectal ultrasound. Okay. The explanation of why makes sense to everybody. Okay, is this BPH should be happening symmetrically. If we have asymmetry, it means something's growing on one side and not the other, and that's a sign of badness. Urinalysis and culture, again, just to rule out any infected urine, because we are expecting an increase in PVR, so just as a baseline exam, it's important to get it and make sure it's not there. We need to make sure, again, what is the obstructive process called? When we think about the nephrology section. Obstructive uropathy, post-renal kidney injury, right? Post-renal kidney injury. So we want to make sure BUN, creatinine, and EGFR are not declining rapidly, which in an older population might necessitate we look back at some older labs to make sure that we haven't had a steep decline, because we do expect a sort of a decline in EGFR, maybe a slight increase in BUN and creatinine with normal aging process. So what I'm saying is, don't just use a snapshot in time. See, like a more recent lab, the last time they got labs, compare and make sure they're not sharply declining. Because if they are, then it's more likely that the post-obstructive, obstructive nephropathy may be happening, which would necessitate more urgent care. Okay. And serum PSA, we're going to talk a lot about PSA in the prostate cancer section. For BPH, I would just get it. All right, it's becoming the standard of care, has essentially become the standard of care to establish baseline PSA scores for younger men, than to be so you can track PSA increases. Okay, so PSA at baseline when you're diagnosing prostate is warranted. You don't need to get, this is a primary care disease all day. BPH is something you're going to see on a very regular basis. Unless patients have very, very severe symptoms indicated by a very high IPSS or AUA score, then medical therapy, symptomatic care is warranted at first before you need to go get any kind of ultrasounds or MRIs or CTs or anything like that. Okay. Differential diagnosis, again, it's this patient is too young, this is weird. Bladder neck contracture would also probably come with some more incontinent type signs, some spastic overactive bladder incontinence type issues, which we'll discuss in a later lecture. And again, prostate cancer, only if that patient is lucky enough to have the lesion growing in the right spot, okay? So, let's see here. Let's take a 10-minute break now so we can get into the treatment and get as far as we can into cancer, and then we'll cut it, all right?
Yeah, talking about 7 and see if I can 27. Good question.
Hey, what do you do about it? You get tears? Tears?
They don't cry until then?
They cry, but no tears.
I try some. Yeah. It's a lot like this green. A lot more spice.
It is what it is.
It's good. It's like wife made like
Hey guys, couple quick announcements before we get back started. Okay, so first one, the due date for PCS leave is going to be March 31st, the end of this month. So just keep that in mind if you haven't put it in yet, March 31st. And then guard people whose orders don't cover your entire PCS time, you can go by a DA 31 through the NCOs. That's going to be your, like, how you're covered. Next thing, we still need a new MC for graduation because Major Rogers cannot do it. So I need to turn a name in for that by the end of this week. So please think about it. If you have any suggestions whatsoever, throw them in Discord.
Hard pass.
All right. I mean, I guess if you really want.
He doesn't want it.
You said I'll do it. Settled. Oh, there you go. All right. Picked the wrong time to be on the podium. Okay.
We're all feeling good.
Next thing, I know we had talked about whether we can compress the schedule for Thursday, but there's a couple issues with it. First one is we've got some appointments that conflict, and then the second one is We have a mandatory briefing from the company now on Thursday afternoon. It was just added over executive order number 14183. I took the liberty of looking that up for you guys, and it's the transgender in the military policy. So we now have a mandatory briefing in the afternoon following the conclusion of DERM on that executive order. Everyone has to be there. I don't anticipate it to take longer than like 30 minutes, so you probably will still be out by 1500 if I had to guess, but don't quote me. And then that room number, if you didn't get it for the ethics presentations, is 0201 Alpha. I just wanted to repeat that in case anyone didn't hear it. So it's in the basement. And that's it. Unless there's any questions. Cool, thanks.
Yes, thank you. All right. Okay, what are we doing? I forgot about that. BPH. All right, so treatment symptoms, like it's not going to improve, meaning the hyperplasia is generally going to improve, especially without any kind of medical care. That doesn't necessarily mean that symptoms won't regress. I know that doesn't make sense, but just understand that. So not everybody immediately has to be started on treatment just because they have some BPH-like symptoms. So again, how do we get these numbers? The scores. We have them fill out the IPSS score, the self-directed scale, and they tell us how much of an impact this is to their life. And that does help us direct from either watchful waiting, conservative medical care, or an earlier referral on to potential invasive care. All right? So we obviously tend to try to reserve invasive care for those who absolutely need it. It's not as liberal as it used to be, right? Most of the time, if you had a sufficient score, back in the day, you would go get a TURP, a transurethral resection of the prostate. And that was not without severe potential side effects, right? And that's also one of the reasons why PSA was for a long time quote unquote controversial, because what do you do with it? So just understand that just because your patient has some of these symptoms, there is a shared decision-making process that goes along with your patient. Because the inherent nature of BPH is that it is benign. The process itself is benign. But the sequelae that can come from it, meaning chronic urinary tract infections, potential post-renal injury, are not benign. So does that make sense? So you do have time. This isn't like cancer. This isn't like something that needs immediate and urgent treatment, except for a couple of cases that we'll discuss here in a minute. So that you can do some shared decision making with your patient and decide what they want to do. Long story. Short version is, if they have an IPSS score of less than 7, that's established as what they call mild. So you can recommend, if your patient chooses, watchful waiting. Let's follow you up in 6 months or sooner as needed if your symptoms start to get worse. And then we can talk about medical therapy, all right? So if that's not the case, if they're 8 or over, then we get into mild/severe. And where does the ending of severe? All the way to the end of 35, right? So there's no like extra severe. So if they're over 8, we're in sort of the treatment recommended category, all right? Where we really want to have the discussion of the how should we approach this with your patient. Now, if you look at for those of you who do look at these things, these algorithms, if you see here, patient over 8, optional study. So don't think that you have to proceed. Everybody who goes from 7 to 8 needs all of a sudden these sort of systemetric studies. It's not necessarily the case. It depends on the patient in front of you. But people will look at algorithms and go 1, 2, 3, 4, 5. Don't think about it that way. It's not a 100% step-by-step progression. It's just a way to approach patient care. So that's why I went back to it. You can still offer this patient watchful waiting. Now, the majority of our patients in this category are going to be medical therapy, conservative medical therapy, right? And that means the meds we're going to talk about. If they are really, really to the end of it, and especially if you notice that IPSS score at the bottom of it was a quality of life assessment. How do you feel that this is affecting your quality of life? Not at all to very much, so whatever the scale is. If that patient is really complaining of very, very severe, constant symptoms that are a huge quality of life issue, whether or not you think in your clinical judgment this patient is a surgical candidate, who should make that ultimate decision? Urology, right? You have those consultants to make that decision. Is this patient a good surgical candidate? Or is it sit down with the surgeon, going to help that patient understand that maybe it's not as severe as they feel. Don't forget, that is a subjective a subjective scale. Some patients will tend to over-exaggerate, right? But then they sit down face-to-face with a surgeon and they discuss the risk benefits of those truly invasive surgical procedures. Sometimes the patient will then, okay, let's try medical therapy first. Ultimately, that is a conversation that should be had with the surgeon, all right? You could start that patient on medicine, absolutely, but I would not recommend that you be the one to say, no, you're good, and just send them on, let them have the sit down consultation, do the best part of valid for your patient, all right? So watchful waiting, again, is a possibility, depending on how bad they are. But all of these are going to be both useful for everybody who has BPH and also the most difficult things for them to do, right? Because these are therapeutic lifestyle changes in general. Reduce caffeine and alcohol, well, that's the tough one, right, for patients in general. Kegel exercises, just, your patients don't do them, all right? Your patients won't do them. I don't know why, but they just won't. Okay, so if you can get them to do them, and everybody knows what Kegel exercises are, that's, increasing the strength of your pubic muscles to try to help reduce some of the symptomology of BPH. Also, we're going to talk about them a lot when we get to incontinence. All right, increase physical activity and weight loss. That may be the hardest one on this list, right? Stop smoking should be on here, but it's not, but it should be. I will talk about non-voiding regimens. I think I mentioned it in bladder pain syndrome, interstitial cystitis, right? If the patient has these obstructive, more so irritative voiding symptoms, if they can empty their bladder more frequently, then they may have fewer symptoms, right? If they're just emptying the bladder, even if they don't have to go on a regular basis. But what's the problem with BPH in general? Going to the bathroom all the time is their main problem, right? So they don't like that, okay? So they don't do it. Does that make sense, everybody? So again, easiest things to do, hardest things to get patients to do. What do patients want? A pill. Okay. Now, I know you guys have talked about these before. The azocins, we really don't use too much anymore. The ocins is what we really stick with now, all right? Alpha-1 alpha blockade, more selective to the smooth muscle, okay? So not as much of a risk of the patient having orthostatic hypotension, right? So the last thing you want is for this patient to be on one of these non-selective alpha blockers, get up in the middle of the night to go to the bathroom, pass out, and wake up on the bathroom floor, right? Which is what happens in any case. So alpha-1 alpha blockers have a lower incidence of that, and so as long as the patient's fairly hydrated, they'll be just fine. These will be also, what else did I talk about you use these for? Besides prostatitis, we talked about that today. What else? Anybody remember medical explosive therapy for kidney stones? That's, I know, forgive all the red ink, but that's these guys right here, okay? That's your medical explosive therapy or your kidney stones. Same mechanism. Opens up the passageway. Helps either the urine come out or the stone come out, okay? See, you have a small arrow on this side, and look, a much larger arrow on that side. So that's what they do. Okay. Now, 5 ARIs. The main indications are patients with a lot larger prostates, right? Okay. Or a higher PSA level at the time of diagnosis. And these will actually serve to help reduce the size of the prostate. Why are these first-line standard of care for everybody? I don't know. All right? But right now, the main indication to start somebody on these device, a alpha-1 alpha blocker, are those indications right there. Real, much larger prostates, okay? And prostate greater than 30 cc documented on ultrasound. Right? When you were in the GU lab, probably for clinical skills, they had that little card with prostates that have different cc's. Good luck, unless you do this every day, multiple times a day, being able to relate a palpation to a certain cc size, okay? But ultimately, what do you think the problem is with these guys? Like, what might you think that you need to go to this earlier, besides the obvious of these signs right here? Worst symptoms generally, all of what you're saying, not necessarily urinary retention, because that's going to be something we talk about here in just a minute. But usually worse symptoms, higher up in the score, doesn't correlate necessarily, but most of the time the patients who have these symptoms will have worse overall less urinary tract symptoms. Okay? And then this is the thing. These are the two 5-ARIs that you'll use, but this is the key right here. Okay? When you get a baseline PSA, let's say it is 1.5, okay? You put the patient on finasteride or dutasteride. When they come back, the next PSA you get, you need to double because they will artificially lower the value, right? So if you come back and that patient has a 1.5 PSA again, they really have a 3. And so if you're not tracking that, you're missing their PSA dramatically increasing. You guys get that? That's really important to understand about patients on those medications. Especially because we're talking about prostate. You have sudden, severe increases in PSA, now we're thinking that it may be something more insidious than a BPH, okay? So just remember that. It's a simple math to do, just double it when they come back so you have a true picture, right? And so what also that means is if they come back and they have a 0.75, it doesn't mean their PSA has gone down. It just means it hasn't changed, okay? Combination therapy, we usually, again, stepwise approach. You know, patient comes to you, regular symptoms, alpha-1 alpha, a little bit worse, some of those indications that we had in the previous slide, start them on a 5-ARA, put them together if they're not getting any better, right? Another step before we get to invasive therapy, right? When you get to a certain age, polypharmacy becomes a real problem, like taking a shitload of pills every single day. So if you can do 2 pills for one pill for 2 things, excuse me, that's good. It also increases patient compliance quite a bit. So if you have a patient who has erectile dysfunction and BPH, Cialis is actually indicated for both. Cialis is usually a PRN medication, meaning as needed before sex, right? But in this case, the patient takes a half dose every single day, and it affects BPH and their eating, all right? Now, this would go to urinary retention, right? Refractory urinary retention. Absolute surgical indications. What's going to make us send this patient right away for surgery, regardless of either their initial presentation or if they're just not responding to medical care? And so again, if they're developing chronic kidney disease, if they're peeing blood all the time, they keep coming back with UTI, or we're getting to the point where they come back on a regular basis with anuria, rather than we have to empty their urine for them. Obviously, it's time. Medical therapy is not going to affect change fast enough to stop these things, so they need to have their prostate, or at least part of it, removed. Open up the passageway. Does that make sense? Okay. All right, now this is the part where you guys don't have to memorize. This is not testable material, but it's stuff that I want you guys to understand, because these are the things your patients are going to be going through. And so you can have this discussion of what might happen when I get to the urologist's office. Or the other thing is patients will often, you'll be surprised, they will go to a consultant, they will discuss a surgical procedure, they will not understand, but they will not ask questions, they will come back to you for you to explain to them what their surgeon told them about, right? So it's good for you to know this stuff. Just MIT, minimally invasive, MIST, you'll see it, minimally invasive surgical therapy. So MIST therapy you'll see often, all right? This one is becoming more prominent here, UroLift. So they actually lift part of the prostatic urethra, which opens the passageway and it helps just move everything along. Minimally invasive, so it's sort of like a same-day surgery kind of thing, all right? Electrovaporization, exactly what it sounds like, lasers. They can use lasers, so laser enucleation, so part of the prostate is sort of eaten away with the laser. Again, just opening the passageway. You ever seen like an aquajet machine, like cutting through metal from, making that, but in your prostate? All right, not really, but now you remember that. So again, just sort of eating away the prostatic tissue around the urethra, opening the passageway up. water vapor, thermal, so super hot, super condensed steam. Again, doing the same thing. So just depends on what your patient's gonna get. Holmium or thallium laser enucleation. Lasers to remove the anterior prostate, same thing. Laser enucleation, they take it, they enucleate it, meaning opening it up, cutting away part of a sort of the round organ, and then removing it through the bladder, okay? This is the more conventional surgery, where it's sort of, you're sort of actually literally boring out that material. This has a potential for some severe sequelae, obviously bleeding, infection, but more severely because of where it's located, erectile dysfunction or urinary incontinence are possible, which is why it is not necessarily a benign process. We try to move this far down the line as possible as far as treatment options. And then you can have an open surgery or a full simple radical prostatectomy, which may be more likely if the patient has prostate cancer versus BPH, right? They really have to fail a lot of things before this would be considered for BPH, right? And that's why these minimally invasive surgical therapies are becoming much, much more common. If you have a BPH patient, I wouldn't be surprised at all if that patient ends up with one of those. Or if you have a patient that is post-surgery with that. Okay, so again, not on the test, but need to understand what it is, know that it exists, and be able to discuss treatment as far as treatment options with your patient. But as you get there, if you have somebody who's failing medical therapy, just Google some stuff and talk about it later. All right. Excuse me. Any questions about BPH?
All right.
Excuse me. Sorry. Okay. Now, prostate cancer. Any questions so far before we transition into this? Anything that's unclear? BPH is pretty straightforward, I think. All right. The key takeaway is just understanding the exam and understanding the IPSS score really and how to interpret that, what to do with it. And it really is all day, every day a primary care issue until they really fail our treatment. All right. And like I said, the IPSS score, it's crucial because it helps us understand much more objectively than a patient description if what we're doing is making them better or not. All right. Okay. Prostate cancer becoming common, which is to say more common. All right. So we're going to get to the end here and talk about AUA guidelines because there are conflicting guidelines. We'll talk about USPSTF versus National Cancer Network versus American Cancer Society, and so on and so forth. But I will tell you this now, just so you know, as a preface, the guidelines I want you to know and I would recommend you practice with are the AUA guidelines. Okay? We'll get there. Asymptomatic for many of the reasons we already discussed. Depending on where the lesion is growing, it may not be palpable, it may not be impinging upon the urethra, which means it's not going to cause much in the way of symptoms. Okay? So, do you guys remember red flag questions for lumbar spine pain? Like loss of bowel or bladder, saddle anesthesia, pain worse at night, pain, fever, of course. Yeah. So one of the reasons is one of the common sites of metastasis for prostate is low back. So that's why we try to cross those off as potential red flag signs and symptoms to make it think it's more than mechanical low back, right? Again, you can appreciate where the physical portion of the organ, remember that green section, where the prostate is. Most of our cancers are going to grow there, most not all, so it becomes, again, if you suspect prostate cancer, it warrants a referral for a further evaluation, meaning a radiograph. Just general, right? This should make sense as our general cancer labs involving a prostate. We have the PSA, right? Nothing specific there, really. But how much discussion of PSA have you guys done, like in clin lab? Did you guys talk about it much at all? All right. So the problem with PSA is that there really isn't a defined level that says good or bad, refer, don't refer, all right? So it's up to interpretation. And it really, when you get to these guidelines, there's gonna be a lot of the phrase shared decision making, all right? It's becoming much more in favor, or has become, to obtain PSA scores. There used to be guidance that said don't get a PSA score at all. But then we noticed epidemiologically that when we would receive cancer patients, they would be at a worse stage of cancer. Okay, so it's sort of called stage creep or stage regression, right? So then the guidance shifted back to maybe we should check PSAs. So again, as a primary care provider, what do we typically do? We look to the society guidelines of the AUA, who are our prostate docs, to say, what should we do? And the guidance has gotten a lot more clear, but it's still a little nebulous. So let's talk about what we should do with PSA. The 4 nanogram per deciliter is, it's what they used to define as high, okay? But ultimately, it is variable based on the patient in front of you, more specifically, the patient's age in front of you, all right? And so, it's like it says, you have no value for PSA. Like most of the time we look for someone and say, okay, if we have a value above this, we need to do this. If we have a value below this, we can do these other things. That doesn't exist here. We have to put the whole patient together. It makes it a lot more notoriously difficult. So you have, and you don't memorize this, all right? But essentially, what you have is, as you age, your PSA tends to get higher. So a higher level of PSA at an older patient isn't necessarily portend a poor prognosis as it does maybe for a younger patient, right? So I am less than 50, so if my PSA is 2, that's not good. That's elevated, right? So a lot of times what the recommendation is to start screening patients early with PSA value, and then be able, it gives you a baseline with which to track PSA evolution. Does that make sense to everybody? And if it doesn't yet, it will when we get to the slides. The takeaway really on this one isn't necessarily for you to memorize that, as it is to know that there are risk calculators that you can input the patient's PSA. They're standardized risk calculators. And that as your patient gets older, their PSA is likely to go up. So what does that mean for you? Higher PSA scores at younger ages should prick your ears up a little bit, right? What does that mean? Clinical intuition, which you don't have yet. Hold on, we'll get there. The reason why PSA used to be much more controversial is because they would assign cutoff scores. And so, if a patient had a PSA score that was elevated, they would be referred on for a transrectal ultrasound with biopsy. Okay? Transrectal ultrasound with biopsy is not a benign procedure. Where the prostate is right around the urethra, right around the ejaculatory ducts, if the biopsy went wrong, they could have those similar sequelae of a TERT, like urinary incontinence, like ejaculatory or erectile dysfunction, and then of course bleeding, pain, infection. Okay, because when you take, when you take a biopsy of a solid organ, right, especially back before we had the more precise MRIs, you had to take several samples, right? You don't just take one sample. So again, it was not a benign procedure. You go back, this is the big takeaway, is that you're not going to, still to this day, base any treatment decisions, especially surgical decisions, on a PSA number in isolation. Okay? So, let's go back to this. This is why PSAs become more in favor. This is a multi-parametric MRI. It is a direction MRI of the prostate, and it helps identify cancerous and precancerous areas. It really helps direct the areas where the biopsy, a much more focused biopsy can be done. All right? So it makes PSA screening less potentially dangerous because fewer and fewer patients are going to need to go to the biopsy because this would come first. Does that make sense, everybody? So instead of going directly to that giant needle, they get this. If we don't see anything on an MRI and the PSA is at a certain value, then they don't need to proceed to biopsy. So really only this subset of patients who are at much higher risk of actually having prostate cancer would move on and receive the biopsy. Okay? And so again, I don't know if I have before, but I usually refer to MRIs as surgical planning tools because that's generally what they are. All right? And it shows us the areas, and that focuses in the surgeon's biopsy, so they're not just going all over the place. So it's a much lower risk, significantly lower risk, I would say, of just taking samples of the entire organ, okay? Does that make sense? Yes?
Are we referring them for this
Yeah.
versus the urologist?
You're referring to the urology. You think so, like bottom line up front for prostate cancer, if you think this patient has prostate cancer, you're gonna refer them on. You're not gonna order the MRI and route. If you think cancer, they need to go to somebody who can do something about it. So yeah, you wouldn't order this.
Okay.
Yeah.
So exam and then plus or minus.
Exam, labs, send. Yeah. Okay.
So is there an evaluation you recommend testing?
We're gonna get there. We're gonna get there. Yep. We're gonna get there. Just give me a sec, because what I'm gonna talk about cancer in a general, and then we're gonna move. The last portion of this is gonna be screening. Okay. So, Gleason scoring again. You don't have to know Gleason scoring. You don't have to know this. You don't have to know this. So don't spend time reading about this. The reason why you have to know this is because it is a specific eponymous scoring system for prostate cancer. So when you get back, you're not going to get a TNM score, you're going to get a Gleason score, and you need to know that those are the same thing for prostate cancer. Does that make sense? So you need to understand and be able to communicate what does a Gleason score of X mean to your patient. Not now, not in an exam, because you're not going to be doing that. You're going to receive a report that tells you the Gleason score. The reason why I don't have you guys stage tumors is because you won't do that. All right? So does that make sense to everybody? But you do need to understand and interpret the scores. Okay? So, let's talk about Gleason scores. It makes me laugh because it's such an iPad thing, and you'll understand in just a second. So what they do, everybody knows the difference between, you've had your oncology now. So we all know what well-differentiated versus like anaplastic or poorly differentiated is, right? Well-differentiated means the cells around the other cells are like those cells, meaning they're supposed to be, they have differentiated into the type of cells they're supposed to. Poorly differentiated means they're just whatever. A mishmash of whatever cells, worse, right? They're worse. They have undergone no differentiation whatsoever, right? So, when you look at that, patients will undergo biopsy, right? The pathologist then will determine the most prevalent number, or the most prevalent type of cell from 1 to 5, and then the second most prevalent type. And those two scores will be added up, and that will be their Gleason score. So as you can see, a higher Gleason score is worse, right? Make sense? Okay. But here's where it becomes fun. 7 in IPAP doesn't always equal 7. All right? And it's because of the math I just told you. In the green box one, the most prevalent type of cell is the more differentiated, less dangerous number 3, right? The second most is number 4. That is 7, but it's still a lower score. In the yellow box, the 4, which is the worst looking, less differentiated cells, are the most prevalent, whereas the 3 are the second most prevalent. Does that make sense? That's why there is a 7 that's worse than the other 7. It's important for you to know something as seemingly stupid and innocuous as that, is that it doesn't mean the same. Does everybody get what I'm saying? Like I said, they take the most prevalent type of cell and the second most prevalent, and they add them together. Those two numbers can be the same, even though they mean very different things. Does that make sense? No? What doesn't make sense? Math, I know. So, the reason why there's more worse stuff here, that's why 4 comes first. All right? There's less worse stuff here, that's why 4 comes second. All right? That's why this one's yellow and that one's green, even though the number equals 7. You guys get it? We don't have to prolong this because it's not going to be on the exam. I just want to point it out because it might not mean the same thing. You very well might get a patient that has a Gleason grade of 7, Gleason score of 7, and depending on where they are, that might mean we're just going to watch the cancer versus we're going to be aggressive in treating the cancer. And it's important that you know this stuff, all right? It's a pathologist score. They're not going to have this explanation for you. They're just going to spit it out. This is what it is. Gleason score 7, Gleason grade group 3. Just understand that it can mean something different, all right? Just understand why. Like again, this is the why behind the what. If you just want to memorize the scores, that's fine. You don't have to do that either. You guys are done with me today, huh? All right, I don't care. So, treatment for low-grade disease. Everybody know the difference between active surveillance and watchful waiting? Okay, tell me. Oh shit! I just wanted to say yes and move on. So tell me what it means. Regular follow-up versus just a routine follow-up, right? Watchful waiting. We just let the patient kind of come back to us if it gets worse. Active surveillance means we're going to watch this patient on a regularly scheduled basis. They're going to come see us at least this often, if not more, if they get worse, and that's the difference. So you might see, it might seem counterintuitive that any cancer would be treated with watchful waiting, but the truth about it is, depending on the severity of the cancer itself, prostate cancer is notoriously slow growing. It's a cancer typically of older men. And of course, the treatment for it is not entirely benign in any way, shape, or form. So there is a likelihood for some patients in certain demographics that they will outlive the cancer. Okay? So the treatment is worse, potentially, than just leaving the cancer alone and seeing what happens. All right? So that, of course, is made, the decision is made by the oncologist and urologist, but you have to understand that patient with active prostate cancer will come back to you because they won't stay with that patient entirely, all right? So you might have a patient that is undergoing active surveillance of their prostate cancer. And what does that mean for you in primary care? Observing to see if they're showing signs, symptoms, or lab findings that suggest their prostate cancer is becoming more aggressive or worsening, right? That would indicate a faster referral back to their oncology, all right? So, 3 different types. Again, you don't have to know this. These are broad-based general types. There's the active surveillance I just talked about. There's focal therapy for patients with localized cancer. And then there's whole gland therapy for worse cancer where we have to take the entire gland out or treat the entire gland with radiation. All right? I'll talk briefly. Radical prostatectomy, that's pretty obvious. More advanced, metastatic potentially, local or regional nodes, so we have to take the whole gland out. Not usually a good outcome. External beam therapy, so like focused directed lasers, again, with the use of the MPMRI in order to direct a certain portion of the prostate. Cryosurgery, exactly what it sounds like. Androgen deprivation, depending on if it's in a really testosterone sensitive area, it may be used not usually in isolation, but often in conjunction with other therapies, all right? Again, testosterone being a very sensitive, the prostate being a testosterone sensitive, deprivation of that androgen can help reduce or regress the tumor, all right? Brachytherapy, you might see this, and honestly, you might see a sequel of this, and what it would look like is if you get an x-ray, you'll see what looks like shotgun shot in the patient's prostate, all right? What happens is these tiny little irradiated pieces of metal are implanted into the prostate in certain areas, and they just basically slowly leak radiation. It's like focal or localized radiotherapy. And then once the half-life is sufficient, once the half-life goes away, they just leave the implants and they don't go back and take them out. So that's why you might see them on a radiograph, and that's what they are. Okay? Supportive care, this is not an exhaustive list. Obviously, when you talk about patients with cancer, you're talking about a holistic therapy, so multiple different subspecialties are involved. This is just, don't forget the patient sitting in front of you. Don't just treat the cancer, treat the patient. Cancer patients tend to get treated like, what's the best way to say it? We tend to like really focus on the cancer, forget the person surrounding you. You know what I mean? So try not to do that. Don't worry about this. Kappa nomogram, again, this is more background, that's why I'm just buzzing through it. It's just something that you use using the Gleason score to sort of prognosticate how this patient's outcome might be. You're not going to do it, but just understand that that exists. And now we're in screening. Any questions about just cancer itself, right? Nothing as usual. We're just detecting cancer. And what are the things that make us suspicious for it on physical exam? Asymmetry or induration, right? You got it, right? And then we're looking at elevations of PSA. Not going to use those in isolation. Put them together with the entire patient and their family history, and we'll make decisions from there, okay? So, prostate cancer screening, it's not controversial anymore, really. It is getting tightened up, which is to say it's becoming more focused and directed as far as recommendations are concerned. Still, though, there's confounding guidance. There's confounding guidance. In most cases, you guys are going to defer to USPSTF. But USPSTF still hasn't updated their guidance. If you look, in 2018, prior to 2018, the guidance was to get a PSA. All right, and then those elevated PSA scores led to a number of unnecessary transrectal ultrasounds and biopsies, which then led to a large number of bad outcomes from that biopsy for men who never had cancer or who may have outlived their cancer anyway. In 2018, just for a little history, USPSTF then changed their guidance to make it do not recommend PSA-based screening. So this is old. So if you go to USPSTF, you're still going to find old news because it hasn't been updated yet. It's probably almost there, and look for it to be out soon. But this is typically where we go to look for. You guys know what USPSTF is, I'm assuming, right? You guys, that's where we usually go for our guidelines. But if you go there, you're going to get old news. All right, so just understand that. It's important. And this, if you look at it, undergo shared decision making, and it's still a C grade recommendation. That's a lot. All right, it's no answer. What that is essentially is no guidance. All right, and it became very confounding. So they're huge. What are we supposed to do? What are we not supposed to do? All right, and it was based on this. Approximately 10 to 11% of our patients would be harmed by the outcome of PSA-based screening, right? So that's a significant number. So that's why they changed it. Literally, just at the AUA conference in 2023, they updated with much more prescriptive guidance because, again, what is being seen is a cancer stage migration at diagnosis, right? We were seeing cancers showing up at stage 3 and stage 4. So these cancers that if we had any kind of screening method, we could have done watchful waiting, surveillance, focal therapy. Now we're having to do much more invasive surgical procedures, more invasive chemo radiotherapy, right? So the guidelines are making it worse. That's what the stage migration is, right? We go from identifying stage 1 to identifying stage 3. It's bad. You guys should know that. Okay? So AUA's new guidelines. Shared decision making. What does that mean? It means sit down and talk to your patients about the risks and the benefits and allow them to make a decision, right? You can't force these guys to get PSA screening, but you help them understand the risks of not. That's what shared decision making really is, all right? PSA is our first line, okay? So again, more prescriptive. Because like I said, before this, the guidelines were just trash. It was just like, figure it out, guys. So, here's to answer your question. For patients with routine, like normal family history, no extended risk factors, we're going to get a baseline, okay, baseline PSA, somewhere between 45 and 50, okay? That makes sense? One, baseline somewhere between 45 and 50. So we have a place to start measuring from. If they have increased risk factors, we're going to move that down to 40 to 45. Again, a baseline, all right? What that means, why I keep saying the word baseline, is that it doesn't begin routine annual screening. We're going to get your baseline, and then we're going to start testing you when you get older. Does that make sense? All right. And again, these are the risk factors. And I'll tell you, strong family history generally means about the same thing. At least one primary relative or multiple second-degree relatives. Okay? Diagnosed with prostate cancer, regardless of stage, regardless of age. Okay? Germline mutations, I'll explain that one. Typically, they're talking about the BRCA gene mutations, if they are known to have that, or some of the MEN, but anything like that that would make them at an known increased risk for prostate cancer. Okay? And then, so everybody understands where we get our baseline, right? Then we start every 2 to 4 years, depending on the patient, when they start age 50. So if they decide, I'm an average risk patient, I want to wait and get my first one until I'm 50, that's fine to establish the baseline, but then now we're going to start you every 2 years. Or move it down, depending on the patient. I know that is a huge spread, 2 to 4 years. It just depends on the patient. You have to make that clinical decision yourself. Okay? And again, going back up here, black ancestry, meaning that a patient who is of black ancestry. So you have to know that certain patients are at higher risk so that you can give them appropriate recommendations. All right, so understand that. And then this 7 kind of caveats of what I said about how long this is a big spread. Personalized rescreening interval based on the patient, the patient's preference, what their risk factors are outside, of family history and so forth. So like if they're obese, so all the other risk factors for cancer we talked about. If they're generally unhealthy, maybe you want to bring them in more. If they're doing okay and their PSA is super low, maybe you want to bring them in less. Okay? It is a clinical decision that you have to make together. And then the remainders, let me talk to you about these. DRE indicated, of course. So if you're screening for prostate, if you're talking about getting a PSA, understand DRE is part of it. All right. And yes, doing a DRE can alter PSA levels, but not so dramatically during the same day that the patient's going to have dramatically elevated. And if you're clinical and suspicion, if you just want to be 100% sure, then get the lab and then do the DRE, or have them come back a couple days later and get the lab. All right, something like that. But it shouldn't be something that confounds the findings. And then we'll skip 9 because you don't have to worry about that right now. But this is how you do shared decision making. Validated risk calculators. And there's going to be some you don't have to memorize them. Again, that's why sometimes you go back to these slides, or you just remember there are risk calculators and you Google it, literally. So you take this patient's demographics, right? The ones you're probably going to use are either going to be this one or this one. So European ERSCP or the Prostate Cancer Prevention Trial. Both of them are available on Google. You can see the hyperlinks. But what you do is just like a Framingham score or any of those cardiovascular risk factors, you take the patient's demographic information and their labs, you plug them in, and it spits out a score and it tells you this patient is at high risk, low risk, average risk. And then you show that to your patient and you can have, and they, with you, can make a shared decision about, do I want screening? Do I not want screening? Do I want to come in sooner? So on and so forth. Does that make sense to everybody? Okay. So again, just remember that they exist and remember to utilize them when you're having that discussion with your patient regarding prostate cancer. You don't have to know anything on this other than this. The National Comprehensive Cancer Network, when you get out there and you're practicing, you can go and sign up for an account, and if whatever cancer there is, if you're not remembering what to do about it, click on colon cancer, click on uterine cancer, so on, and it will bring up exactly the most up-to-date guidelines of what to do and when to refer, what labs to draw prior to referral. All right, so it's just a useful database for you. I just wanted to show you this, not that you don't have to remember this one, right? Because it confounds what I told you to remember. But then you go to USPSTF, you're going to see one thing. AUA is going to say another thing. And American Cancer Society is going to say a whole slightly different thing. Okay? So if I were you, I would practice clinically within the AUA guidelines because they're the experts. But just understand, if you do go to other guidelines, you're gonna see confounding information, right? But there's no reason for you to try to remember that because again, I don't want you to know those ones. And just back to the guidelines, just for a slight explanation of what PSA velocity is. It is a serial increase over time, so we document the delta, basically. The change from baseline and how fast it's changing over the course of time. That's what PSA velocity is. And then PSA density is something that can be ordered and it's just calculated by the lab for you. It's slightly useful. PSA velocity more so because, again, if you're tracking somebody with active surveillance, you'll see PSA velocity scores being used quite a bit. So we can really see what the delta is and how fast it's changing. Yes?
Are you doing that, or is that something that like after they cut the base, is that about that?
It's usually done, it's not gonna be reflectively done by the lab. It usually will be a part of active surveillance within like their oncology visits or something like that, or the urology. If you need it, you can get it. You can order it, yeah. But it's not something I mean, I guess ultimately if it's not ordered and you don't see it, get it. But typically this is part of the active surveillance, is seeing how fast we're increasing or decreasing. Okay. And that's it, y'all. Any questions? All right. See ya.